find only one chairperson. Can we go ahead, organizers? Yes, you can go ahead, sir. Chairperson, sir, you may please introduce and go ahead.
Okay, good afternoon. Welcome to this plenary session by Dr. Srinivas on very important and interesting topic, how we can antagonize mineralocorticoid receptors and decrease progression of chronic kidney disease as well as stabilize cardiac function. We all know that steroid spironolactone is actually it is stimulated and produced because of hyperkalemia and hypotension, and it has the effect on the epithelial cells of the distal nephron in order to preserve sodium and excrete potassium. But what we really did not realize long enough is these mineralocorticoid receptors is exhibited on non-epithelial tissues like cardiac muscle, vascular smooth muscle cells, adipocytes, podocytes, and inflammatory cells. And so this gives us an opportunity, if we can antagonize these non-epithelial MR, we can prevent renal fibrosis as well as stabilize cardiac function. So to tell more about this is Dr. Srinivas. Please go ahead.
Yeah. Thank you, sir, for the kind introduction. Respected teachers, seniors, colleagues, and friends. At the outset, I'd like to thank ISN Southern Chapter for giving me this opportunity, and also for thank Nephrology Association of Coimbatore for the wonderful hospitality. I'll be talking on mineralocorticoid antagonists, a new hope for improved cardio-renal outcomes in patients with CKD and diabetes. As we all know, kidney disease approximately doubles the risk of cardiovascular mortality in patients with CKD and diabetes compared to patients with kidney disease alone. If you have neither diabetes nor kidney disease, 10-year standardized cardiovascular mortality is around 3.4%. If you have diabetes, it doubles. You have a mortality rate of around 6.7. If you have kidney disease alone with no diabetes, you end up having a risk of about 9.9%. But if you have diabetes and also kidney problem, then it doubles once again, and you have a risk of about 20%. And even in diabetic patients, if you analyze, the risk of the cardiovascular mortality was more seen in patients who were having kidney disease. Very important observations. Coming further, risk of cardiovascular events in patients with diabetes increases as albuminuria progresses and eGFR declines. So even within the normal albuminuria, 0 to 30, if the proteinuria, albuminuria increases, there is an enhanced mortality. And the GFR decline also enhances the cardiovascular mortality. And within the GFR segment, if the proteinuria keeps on rising, the risk of mortality, cardiovascular, keeps on increasing. All important observations. Till now, we were concentrating on RAS blockade and SGLT2 inhibition in patients with diabetes and advanced CKD who are at the risk of CKD progression. The first study, that is a renal study, 2002, it got published, where we used losartan and compared it with the placebo, where there was a significant risk reduction. Of late, for the next 16 years, no studies were there which showed any improvement in the risk reduction. Then came Credence, which compared canagliflozin. Then came DAPA-CKD, dapagliflozin, and this last year, EMPA kidney came into print. What they all showed was there was a significant risk reduction in patients with diabetes with regards to cardiovascular mortality. These molecules, that is ACE inhibitors, ARBs, and SGLT2 inhibitors, predominantly control the hemodynamic factors and the metabolic parameters in CKD progression. However, we know that CKD progression in diabetes is driven by combined effects of metabolic, hemodynamic, and inflammatory and fibrotic factors. All put together, they cause tubulointerstitial damage and inflammation. They cause glomerulosclerosis, they cause mesangial expansion, and they cause glomerular hypertrophy, which ultimately leads to CKD progression by causing kidney fibrosis. Inflammation fibrosis is associated with mineralocorticoid receptor overactivation through multiple mechanisms. This is very much true in patients with diabetes and established CKD. What are the factors which can cause this mineralocorticoid receptor overactivation? It is predominantly mediated by increased ligand-dependent MR activation by aldosterone itself, increased ligand-dependent MR activation by cortisol, increased ligand-independent MR activation by RAC1 and oxidative stress, and as such, there might be increased mineralocorticoid receptor expression is increased, especially in patients with high albuminuria. So there is a evidence for mineralocorticoid receptor overactivation, and this is thought to drive the inflammation and fibrosis which we see in our CKD progression. In kidney and heart disease, the MR pathway becomes overactivated through multiple mechanisms which we saw, and which in turn results in downstream effects. It causes kidney damage, predominantly glomerular damage, proteinuria, tubular injury, reduced renal blood flow, kidney injury. It can cause vascular damage, causing vascular remodeling, endothelial dysfunction, and increased vascular stiffness. It can cause heart damage, causing myocardial hypertrophy, ventricular remodeling, reduced coronary blood flow, ischemia infarction, and myocardial injury. Let us now look at the current therapeutic options available to us. One, as I told earlier, we use for hemodynamic mitigation, that is ACE inhibitors and ARBs, thiazide-like diuretics, dihydropyridine calcium channel blockers, and SGLT2 inhibitors. And for metabolic control, we use SGLT2 inhibitors, GLP-1 receptor agonists, metformin, and other anti-hyperglycemic effects. Till date, none of the therapeutic arms targeted the third component of the spectrum, that is the inflammation, the fibrosis, which is supposed to be happening through mineralocorticoid receptor overactivation. Here comes finerenone, which is a novel, non-steroidal, selective mineralocorticoid receptor antagonist. This molecule was actually designed in the lab. They studied almost 1 million molecules to come out with the structure of this drug. What they did to make it non-steroidal was they removed the steroidal ring, which we commonly see in spironolactone and eplerenone. So it became non-steroidal that way. It is bulky. The unique structure of this finerenone results in selective and potent interaction with mineralocorticoid receptor and regulation of gene expression. Because of this, there are finerenone-specific gene expression which targets anti-fibrotic and anti-inflammatory effects. So if you use finerenone, you are supposed to interfere with the ongoing fibrosis and inflammation. So here is the comparison between the steroidal MRAs that we know, spironolactone and eplerenone, and the non-steroidal finerenone that we are talking about. The advantage of finerenone is it's very potent to the mineralocorticoid receptor. It is very selective. It has a very short half-life of about 2 to 3 hours. There are no active metabolites, and there are no sexual side effects on its usage. And the effect on BP is supposed to be minimal. So differentiated risk for renal electrolyte disturbance and effect on the markers of inflammation fibrosis. Short half-life, if there is hyperkalemia, you can stop the treatment and hyperkalemia gets corrected. So these are the advantages of finerenone. Finerenone is approved in India. It is indicated in adult patients with CKD and diabetes to reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure. The evidence based upon which the recommendation came about is derived from predominantly two seminal phase 3 clinical trials involving finerenone, that is Fidelio-DKD and Figaro-DKD, and the pooled analysis of these two studies called the Fidelity. Here is again one thing which you need to note. Finerenone has been studied in two studies, that is Fidelio-DKD and Figaro-DKD. The combined number of patients in these two studies comes to around 13,471, which is much more than the common renal studies we have seen so far. Even EMPA kidney, which got published, had around 6,000 patients. So a very large pool of patients have been studied in these two studies. And if you look at Fidelio study, the renal component patients had a higher urinary albumin creatinine ratio and a lower GFR. That is, they fell into the late stage CKD. Patients included in Figaro-DKD were representative early stage because they had lower albuminuria and a higher GFR. And if you combine both the study population, you almost cover the entire spectrum of CKD before dialysis. So, large study population covering the entire CKD spectrum. Evidence was documented by two phase 3 trials with complementary kidney and cardiovascular endpoints. In Fidelio-DKD, the primary efficacy point was time to onset of kidney failure, sustained decrease of EGFR for more than 40% from baseline, or death due to kidney disease. In Figaro-DKD, the composite endpoint primary was time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. The secondary endpoints were complementary. The primary endpoint in Figaro-DKD became the secondary endpoint in Fidelio and vice versa. So if you look at broadly, eligible patients in Fidelio-DKD and Figaro-DKD, key inclusion criteria, they had to be diabetics, age more than 18 years, diabetic retinopathy should have been there for patients with A2 albuminuria on maximum tolerated dose of ACE inhibitors or ARBs for at least 4 weeks, serum potassium less than 4.8 at run-in and screening visit. Exclusion criteria, heart failure with reduced ejection fraction and NYHA class 2 to 4 symptoms, uncontrolled arterial hypertension, HbA1c more than 12, non-diabetic kidney disease, including clinically relevant renal artery stenosis, stroke, transient ICA, ACS, or hospitalization for heart failure, and a very high albuminuria. Looking at the diabetes-specific characteristics at baseline, what is most important is we look at the HbA1c level in the study population. In the Fidelio, HbA1c level was 7.7. In the Figaro, it was again 7.7. In the pooled analysis, it was 7.7. Fairly decent control for our population. So well-controlled diabetes patients were included in the study arms. If you look at the kidney-specific characteristics at baseline, if you look at the Fidelio study, eGFR was lower, urinary albumin creatinine ratio was higher, and serum potassium was acceptable. In the Figaro, it is the other way because it included lower CKD, early stage CKD patients. Here, the eGFR was higher and the albumin creatinine ratio was lower. And coming to cardiovascular specific characteristics at baseline, again, a point to note is the systolic blood pressure. Both the study arms had well-controlled blood pressure. Fidelio, the blood pressure was 138, and in Figaro, the blood pressure was 135.8, which is very well controlled blood pressure. So patients included in these studies had very good glycemic control, had very good blood pressure control. So median follow-up was 2.6 years in Fidelio and 3.4% in Figaro, 3.4 years in Figaro. And to note, almost 99% of the patients were treated with either an ACE inhibitor or ARB, respectively. Adherence to treatment was high, 92% in finerenone group and placebo group. Cumulative treatment duration and number of permanent discontinuations were similar in both finerenone group and the placebo group. Now, looking at the outcomes. So, this is the Fidelio DKD study. On top of maximum tolerated RAS therapy, finerenone significantly reduced primary kidney outcome by 18%. Number needed to treat was 29 at the end of 3 years. Very significant. And the individual primary composite endpoint again showed favoring finerenone. Finerenone reduced urine albumin creatinine ratio by 31% between baseline and month 4 versus placebo. One of the ways to look at the efficacy of the molecule that is being used is by looking at the UACR ratio, UACR. So this shows that the molecule is working because for the effect on the GFR, it takes a longer period of time. So one way you can, when you start finerenone in your patient, one way you can monitor is by monitoring the UACR. Now, looking at the secondary cardiovascular endpoint, finerenone significantly reduced the risk of key secondary cardiovascular endpoint by 14% versus placebo. Again, significant. Now coming to the Figaro DKD key outcome, primary cardiovascular composite outcome, time to cardiovascular death, non-fatal MI, non-fatal stroke or hospitalization for heart failure. The finerenone reduced the risk of cardiovascular primary outcome by around 13%. And the bulk of the benefit for reducing the cardiovascular mortality came from the reduction in hospitalization for heart failure. So, even though the study population did not include patients with reduced ejection fraction. Figaro secondary renal outcomes, again, kidney failure sustained 40% decrease in eGFR from baseline or renal death, showed a 13% benefit with regards to using finerenone. And if you look at 57% GFR decrease, even then also finerenone use was beneficial in this study population. To be noted is the main effect is by decreasing the risk for end-stage kidney disease. Because in Figaro DKD, you are using the finerenone in early stage CKD patients. So you are giving a drug which is beneficial and thereby preventing ESKD. So in the overall population, finerenone reduced urine albumin creatinine ratio by 32% at month 4 and increased the incidence of albuminuria regression when compared with placebo. And this was consistent through the study period. Now coming to the problem of hyperkalemia. Through the study in both Fidelio and Figaro, the mean increase in potassium was 0.2 millimoles per liter versus placebo. And finerenone had a predictable impact on serum potassium. Fidelio DKD, important thing to note was hospitalization due to hyperkalemia was around 1.4% and permanent discontinuation of the trial regimen due to hyperkalemia was around 2.3%. In Figaro, a little bit less, possibly because of better renal function. Hospitalization due to hyperkalemia was 21, that is 0.6%, and permanent discontinuation of trial regimen due to hyperkalemia was around 1.2%. But what is most important is there was no death that was attributable to hyperkalemia in the study populations in both Fidelio and Figaro study, which is very important observation. Now, what they did was they combined the data of the Fidelio DKD study and the Figaro DKD study and came up with fidelity pre-specified pooled analysis. So, fidelity is a large pre-specified individual patient data meta-analysis of Fidelio DKD and Figaro DKD phase 3 trials, including cardiovascular and kidney-specific composite outcomes across the spectrum of CKD stages. So, very large population base. We already know the cardiovascular composite outcome, time to first occurrence of cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for heart failure, and kidney composite outcome, onset of kidney failure, sustained GFR decrease of more than 57%, and renal death. Here again, finerenone significantly reduced the risk of cardiovascular composite outcome by 14% compared to placebo. And this again was driven by the reduction in risk for hospitalization for heart failure. Finerenone significantly reduced the risk of greater than 57% eGFR kidney composite outcome by 23%. Again, significant result. And then they did what was essential, especially at this time. They looked at whether the effect of finerenone persisted in patients receiving SGLT2 inhibitors. So, roughly around 6% of the patients were on SGLT2 inhibitors, and they were included in the study. So, they compared those not on SGLT2 inhibitors to those on SGLT2 inhibitors, and here again there was a significant reduction in the outcomes. And again, the proteinuria reduction happened over and above that of SGLT2 inhibitor presence, which is again significant. And they looked at the data as intention to treat and also on treatment analysis. And here again, all-cause mortality and cardiovascular mortality favored finerenone use compared to that of placebo. Finerenone reduced the risk of sudden cardiac death when compared to placebo. And finerenone also reduced the risk of atrial fibrillation, new onset in the study population. Finerenone showed modest effects on SBP and there were no sexual side effects. Hyperkalemia was increased, but clinical impact was low. So, not to worry about the side effects. So, if you look at the other common RAS blockade studies, the altitude study, the VA-Nephron-D study, and the AMBER study, the incidence of hyperkalemia when you use RAS blockade more than one drug, the incidence of hyperkalemia is much, much more. But in fidelity, when you're using finerenone with ACE inhibitor or ARB, the incidence of hyperkalemia is very less, which is important for us. So with this strong data from these two studies, it has now started to trickle into the guidelines. If you look at the KDIGO guidelines of 2022, a non-steroidal MRA with proven kidney or cardiovascular benefit for patients with diabetes, eGFR more than 25, normal serum potassium concentration, and albuminuria more than 30, you can consider usage of this drug. It's probably a matter of time before it becomes a strong recommendation. So, five of finerenone treatment, key takeaways: initiate treatment when potassium is less than 5, withhold treatment if potassium climbs up more than 5.5, initiate when the GFR is more than 25 and albumin creatinine ratio is more than 30. And key treatment effects, it reduces ESKD by 20% and also hospitalization by heart failure by 20%. Key points: mineralocorticoid receptor overactivation, which contributes to inflammation fibrosis, is a potential treatment target to slow CKD progression. Finerenone, a novel non-steroidal selective MRA, blocks MR overactivation and reduces albuminuria. Finerenone is different from the available steroidal MRAs. Finerenone slows down CKD progression and prevents cardiovascular events by directly targeting inflammation and fibrosis. Fidelio DKD and Figaro DKD results indicate that finerenone is an effective treatment option for cardiovascular and kidney protection in patients with CKD stage 1 to 4 and having diabetes. Thank you.
Thank you, Dr. Srinivas. You were talking about the activation by ligands like corticosteroid and as well as non-ligand pathways, RAC as well. I suppose even hyperglycemia activates mineralocorticoid. So will SGLT together with finerenone will be more beneficial in such patients?
Yeah, definitely, sir. Probably the effect get complemented. So consider usage of SGLT2 inhibitors, ACE inhibitors, and finerenone in the long run might be more beneficial. Yeah.
Are there any study that combined SGLT as well as MR antagonists like finerenone together, which has shown much benefit than what you have shown with finerenone alone?
Not as of now, sir. Not as of now.
Questions from audience?
I have a comment on that. Like you said, the addition of SGLT2 in general decreases the relative risk of kidney endpoints by 30 to 40%. And finerenone on top of that reduces kidney outcomes by 23%. Currently, a study is ongoing which will be out in 2024, combining SGLT2 plus finerenone to see if there is additional benefit is actually confirmed. So currently there is suggestion towards benefit of the combination. And in fact, the combination decreases the risk of hypokalemia that SGLT2 actually may cause. Therefore, I mean, like Srinivas said, the risk of atrial fibrillation is also decreased when finerenone is used, which is believed to be due to its beneficial effect or preventing hypokalemia.
Thank you. Thank you. Any other questions? If there are no questions, I thank the organizers for giving me this opportunity to chair a nice plenary session on mineralocorticoid receptor antagonism in protecting kidney and heart. Thank you. Thank you, Dr. Srinivas.
Thank you, sir.